Hey friends, welcome back to the Journal Feed. My name is Nick Zelt, and this is the only place to get spoon-fed the latest and greatest of emergency medicine. This is, of course, the podcast version of the past week's articles, which this week were brought to you by our authors, Shannon Marcus, Joshua Belfer, Megan Hilbert, Jonathan Brewer, and Clay Smith. Okay, let's get into the second article, titled A Derivation and Validation of a Clinical Rule to Detect Bacteremia versus Contaminants in Positive Pediatric Blood Cultures, a retrospective cohort study out of the Annals of Emergency Medicine. Now, I'm sure anybody who follows up on their culture results knows that this is a very common problem. Contamination rates are actually higher than bacteremia rates by, it's not a lot, but it's a fair amount. The number of false positives is pretty high. Then actual rate of bacteremia is something like 1 to 2% versus the rate of contamination is something like 2 to 3%. So you could get twice as many contaminants as you have actual bacteremias. So the authors figured if they could come up with some kind of clinical decision tool that we could help combat this problem. Not use antibiotics when everybody thinks it's a contaminant and have something to lean on to say, this is why I think it's a contaminant. I'm not going to start antibiotics in this well-appearing child. Or if you're just calling them back because of a contaminant, then say, I really don't think that this is a real bacteremia. So they did a single center retrospective study and they looked back at 18 different possible things which they could use to help them make these decisions. In the cohort that they had of 747 children who had positive blood cultures, 51% of them were deemed to be contaminants. So more than half of the cultures are contaminated. The most common contaminant was Staph epidermidis, and the most likely real bacteremia was from Staph aureus. Now, using a classification and regression tree model, they were able to wean down the variables to just 4 things that you have to consider. Was the gram stain positive and showing gram-negative bacteria or gram-positive bacteria in pairs or chains? This would make you high risk for having a true bacteremia. Or there was medium risk factors, which were time to culture less than 17 hours, the presence of an internal device, like a central line, prosthetic device, something like that, or if there was a clinical suspicion for osteoarticular infections. If you had one of those medium risk factors, then you had about a 60% chance of having true bacteremia. If you had the high risk factor, which was the worrisome gram stain, then you had about an 80% chance of having a true bacteremia. If you had none of these things, then you had only a 0.5% chance of having a true bacteremia. And the only patient that actually was missed by all of these criteria in the study was a patient who was already known to be bacteremic. He was a transfer from another hospital and was already started on antibiotics and then had blood cultures when he arrived at the pediatric center. This type of patient was actually removed and excluded from the validation cohort. So, you can judge your relevancy there, but all the same, you had a very low chance of having true bacteremia if you didn't have any of these 4 components. So then when they used this on the validation cohort, they demonstrated a sensitivity of 99% and a specificity of 60%. Only one of the 83 bacteremia cases in the validation cohort was misclassified as low risk. And then the authors go on to say that given the absence of a better rule, that people should use this one. I'm paraphrasing, but that's absolutely crazy talk. This was a single center derivation and validation, and you should not just use this clinically based on one single study. Given the absence of a better rule, you should continue to do what you were doing before, which is using your clinical judgment and not just immediately adopting some kind of tool that someone made up and has one paper on. Don't do that. But these are reasonable criteria, things that you would have taken into account most likely anyways, which make a patient less likely of having true bacteremia. In a spoonful, these authors derived and internally validated a tool for identifying contaminated blood cultures in the pediatric emergency department. Even though it's probably the best tool out there, you should not use it until it's been externally validated at least once. Okay, then we skip to the 5th article, titled Emergency Medicine Updates Point of Care Ultrasound in Cardiac Arrest out of the American Journal of Emergency Medicine. Who writes this? Of course, it's a review. It's Britt Long. He writes, so many reviews. He doesn't really do a lot of systematic reviews, but he writes a lot of more narrative reviews. Today we're going to be talking about POCUS and cardiac arrest. Now, I'm sure as many of you are aware, survival to discharge after OCA is terrible. It's about 10%. And so theoretically, there might be a lot of areas in which we could improve there. And one such way to improve is, of course, to use POCUS. This is a bit controversial in some circles, but there is room for use of POCUS. So the major pathologies that you are likely to be able to perhaps diagnose as a cause of arrest are going to be tamponade, RV dysfunction, we're looking for PEs here, and occult VF. That could also be important. So about 4% of OCAs actually have some kind of a pericardial effusion, which is actually quite a bit. And I don't know that my experience reflects that, but that sounds like quite a bit. And here, a pericardial centesis could massively improve survival rates. If you had a quick buildup of this, you only have to take off a few cc's for it to make a really big difference. So what are you looking for on POCUS? Well, if you have a diastolic RV collapse, a systolic RA collapse, a large IVC, or sonographic pulsus paradoxus, these are all signs of tamponade. And though the diagnosis of tamponade is, of course, clinical, if your patient is in arrest, then what's a better clinical sign than that? Although do keep in mind that all those clinical signs I just mentioned would only be seen before arrest, because during arrest, well, you're not going to necessarily be able to see all of that with, chest compressions going on. But if you do see a large pericardial effusion, then, you might have to stick a needle in it. How about PE? Pulmonary embolisms cause somewhere between 2 and 13% of arrests, which of course is huge. And these are POCUS signs that we're used to talking about. So large RVs, D sign, clot in transit, things like that. However, you really do have to keep in mind that RV dilation is common in arrest due to many other conditions. RV dilation due to a pulmonary embolism, well, you're going to have the largest RVs, essentially. But the difference is on the magnitude of millimeters, so you're not going to be able to tell per se. So don't use this as a reliable sign of a PE during arrest or even immediately post-ROSC, because just being hypoxemic will make your RV bigger. Having arrested, just within the first minute or two, your RV is going to get a lot bigger as well. Even clot in transit might be the result of the arrest itself, low flow state. So you have to incorporate all of these findings of a possible PE with, hopefully if you have it, a pre-arrest history. So if they had sudden chest pain and, it was pleuritic plus a shortness of breath and they have one leg that's swollen, then that combined with your POCUS findings, heck yeah, let's go, treat for a PE. But without that, if the patient arrives in arrest, these are not going to be very reliable findings. Then the next thing that you might want to try to spot is occult VF. So ventricular fibrillation that is occult is not going to be apparent on your ECG, but if you do a POCUS, then you'll see those ventricles fibrillating. And in this circumstance, you might want to consider a shock. Treating it hasn't been clinically shown to improve outcomes yet, but, it still seems quite reasonable. Now, what else is there? There's also PEA. Nearly half of patients with PEA have been shown to have cardiac movement. And so this you can perhaps suspect to be pseudo-PEA. And that is that their heart is contracting, perhaps, well enough, but their blood pressure is just so low that they're not perfusing. In this circumstance, it's a good candidate for trying some vasopressors. And then while you're at it, of course, you can POCUS the rest of the body and look for other things as well, things that are easier to POCUS while chest compressions are ongoing. You can look in the abdomen for free fluid or a AAA. You can look at the lungs for if the ET tube is placed correctly or if they have a pneumothorax. You can check the legs for DVTs. You can also think about volume status in your patient. There's lots of things you can do with POCUS. Even pulse checks, that's a pretty common use these days, and it seems like it does a pretty good job, especially since we know that your fingers do a really poor job. Fingers are only about 40% accurate at actually finding that pulse, so that kind of sucks. The POCUS, well, it does pretty well, especially if you start getting a little bit fancy and looking at velocities and such things. You're going to find a pulse if it's there. Speaking of fancy, there's also TEEs, so transesophageal echoes. And these are getting pretty interesting. In CPR, you can use it to make sure that you're actually doing compressions in the right place. Compressions are the most important part besides electricity, and the majority of compressions are not over the ventricles, rather over the aorta or the LVOT, and that's just not the best place to be doing compressions, unfortunately. People get worked up about the possible complications of shoving something down someone's esophagus in this circumstance, but complication rates are less than 1%. Compared to a population that we said has a 90% mortality rate, this could help, especially if you're going to be able to perfuse them better by compressing over the right part of their heart. Now, if you want to have some prognostic value, then just seeing cardiac activity on your POCUS gives your patient about a 10-fold higher rate of survival to admission, at least. But if you have no activity at all, then this is only 60% specific for never getting ROSC, so it doesn't mean everything, but, it still means something. I wish it was more useful for termination of resuscitation purposes, but alas. And that's about it. That's most of the ways that you can make use of POCUS in cardiac arrest. So are you going to bring a POCUS to your next arrest? I can't remember the last time I had arrest that no POCUS was used at all. Am I using it for all of these things? Not necessarily, not routinely. And the most important thing is that you don't let it get in the way of all the other things that you should be doing. Do not prolong your pulse/rhythm checks. Just do POCUS when you can and don't let it mess up the other stuff. In a spoonful, yeah, I'd say it's a good idea to bring a POCUS to an arrest. Just don't let it get in the way. Okay, that's all the articles from this week. Let's do a quick wrap up of everything we talked about. From the second article, we saw the derivation of a tool for spotting blood culture contaminants that does a pretty good job in this pediatric population. But wait until it's been externally validated before you actually use it. And then from the fifth article, I like to have a POCUS around during my cardiac arrests. It's more information. So as long as you don't let it get in the way of what matters, that is compressions and electricity, I think that it's a useful tool. All right, now if you are hearing this right now, then you are not a part of the members feed, and so you missed 3 articles from this past week. That's right, on the members feed, we cover 5 articles every week. If you're not a member, you only get 2. So what did you miss? Well, we talked about just how racist O2-sat probes are. Then we talked about non-injectable ketamine. Does it do a good job for sedations? And then finally, is anyone still doing a pericardial synthesis for trauma anymore? Links to all the original articles can be found at journalfeed.org or just follow the links in your show notes. Our goal here is for you to keep up the easy way through spoon feeding. Thank you.